Good morning, good afternoon, good evening. It depends where you are in the world. My name is Thomas Bohmann. I'm from Lexington Medical, and I'm very happy to welcome you, more or less 100 attendees which registered for this webinar around the world for this first joint webinar with Lexington Medical and Pulmonx with the topic of lung volume reduction under the roof of interdisciplinary. I'm very proud and thankful to be able to welcome our speakers. So ladies first at this point, Ms. Dr. Steinack from the University Hospital in Zurich in Switzerland, Dr. Schneiter also from the University Hospital in Zurich, and our lead for this webinar, Professor Bölükbas from the Roland Clinic in Essen in North Rhine-Westphalia from Germany. This webinar has been accredited by the Swiss Society of Thoracic Surgery and also the Society of Pulmonology with one CMR point. If you need a certificate after this webinar, it would be good just to send an email to my colleague Kerstin Reichmuth. You got an email from her for this registration, so every one of you should have her email. If not, we will see how we handle it after this meeting. So now I wish you an interesting and discussionful meeting and hand over to our lead of this webinar, Professor Bölükbas. Thank you.
Warm welcome also from my side. I'm very happy to chair this session, this webinar session. The topic is very hot. It's lung volume reduction. It could be done bronchoscopically, it could be done surgically, but there are also patients who will not profit from either approach. Therefore, I'm very happy that we have two experts from the one side, bronchoscopic side, and the other side, the thoracic side, who will explain us the way how it is done in Zurich. I can tell you, I attended a lung volume reduction surgery event a couple years ago, and it changed my mind. And I think you have good news for us, and maybe we have colleagues afterwards who will change their clinical practice. And I would like to invite you both to start your presentation, please.
Okay, thank you very much for this kind introduction. I will share my slides. You tell me whether it's okay. Can you see my slides?
Yes.
Okay, so I will start. Thanks a lot, dear Servet. Thank you for the kind introduction, and many thanks to Lexington for supporting today's webinar. I'd like to begin by sharing some insights into our multidisciplinary approach to patient care, in addition to our key partners in the pneumology department, close collaboration with our colleagues in anesthesiology, radiology, and physiotherapy plays a crucial role in the treatment algorithm for this particularly fragile patient cohort. In the second part of the webinar, Dr. Carolin Steinack, one of our interventional pulmonologists, will present on in the bronchial lung volume reduction. These are my disclosures. So depending on the source, COPD ranks as the third or fourth leading cause of death worldwide. Among the 10 most common causes of death, it is the only still increasing in prevalence. Chronic obstructive pulmonary disease is a global significant health issue affecting more than 380 million people and accounting for over 3 million deaths annually. In addition to its clinical impact, COPD remains a major contributor to healthcare costs worldwide. Reasons for this unending process with the still increasing COPD population are inhaled toxins, mainly due to tobacco abuse and air pollution. It's a global health issue, with cigarette smoking being an important risk factor universally. Other factors such as exposure to indoor and outdoor air pollution and infections are also important. As the global population ages, the burden of COPD will increase in years to come. Furthermore, studies have shown that comorbid chronic conditions occur more frequently in patients with COPD than in subjects without COPD and contribute to poor clinical outcome in these patients. The challenge we are facing are implementation of cost-effective prevention and management strategies to stem this tide of disease and its costs. Lung emphysema in COPD is an unstoppable chronic disease leading to physical impairment and anxiety. Chronic emphysema's destruction of the lung leads to shortness of breath and a concomitant decline in physical performance and quality of life. The chronic inflammatory destruction of thermal and bronchial wall leads to loss of recoil, hyperinflation of the lungs, and impaired gas exchange. Lung volume reduction surgery has been proven in several prospective and few randomized controlled trials as successful palliative treatment for selected patients with end-stage emphysema. Nevertheless, up to date, LVR is still not performed in large parts of the world, or only hesitantly. So this diagram illustrates the natural progression of lung function declining over time. As expected, the deterioration is significantly more rapid in smokers with lung emphysema. However, as the graphic shows, smoking cessation remains a crucial component in the management of treatment of these patients, as it can significantly slow the rate of decline. Staying moderately physically active can lead to a significant survival benefit, about 7 years longer on average compared to people who live in a very sedentary lifestyle. During the follow-up period, 60% of the participants of this study died. Of those, 18% died from respiratory distress and 32% died from cardiovascular causes. What's especially important to note, people who were less physically active had a much shorter time to death. So even moderate activity can make a real difference in outcomes. Because of dyspnea progresses slowly but steadily, the medical history of patients with end-stage COPD and emphysema often stretches over many years. By the time drug therapy no longer provides relief, many patients are told there is not much else that can be done, which can be incredibly disheartening. But that's not the full picture. In selected patients, lung volume reduction can offer meaningful symptom relief, improved quality of life, and even better exercise capacity. These options represent an important next step in care when conventional therapy reaches its limit. National and international guidelines support lung volume reduction as treatment of choice in selected patients, shown here as evidence A for LVRS and BLVRS. Patient selection for volume reduction surgery is conducted through a dedicated weekly multidisciplinary emphysema board, ensuring individualized evidence-based decision-making. The board includes thoracic surgeon and a pulmonologist extensive experience in both LVRs and bronchoscopic valve therapy, as well as discussion with thoracic radiologists, physiotherapists, anesthesiologists, critical care specialists, and special nursing staff. The program is closely integrated with the institutional lung transplantation unit and allowing for comprehensive evaluation and seamless transition to alternative advanced therapies when appropriate. A structural network for preoperative and postoperative pulmonary rehabilitation is in place, optimizing functional status and surgical outcomes. The preferred operative approach is video-assisted thoracoscopic surgery, typically performed bilaterally. A non-anatomical volume reduction technique is used, employing buttress stapling to minimize postoperative air leaks and promote safe, efficient resection of emphysematous lung disease. Through workup, standardized preoperative functional assessment is indispensable. Lung function tests with body plethysmography, transthoracic echocardiography and right heart catheterization if necessary, as well as morphological assessment with a CT scan with charges measurement and lung perfusion scintigraphy. Every candidate is discussed in our multidisciplinary emphysema board to achieve the best possible patient selection to decide whether a surgical or an endobronchial valve is preferable. Here you can see a densitometry with showing the red areas with trapped air, and as an example, the Stratex lung report for the decision whether the bronchial access is a good idea. Besides clinical workup, patients need to fulfill the following. They had to conclude a rehabilitation, smoking cessation with minimum of 3 months, expanded drug therapy, and in the diagram below you can see the relevant contraindications, especially on pulmonary function when you see that DLCO and homogeneous emphysema in combination is an absolute contraindication for an LVRS. Here you can see a typical chest X-ray of a patient with an emphysema showing increased lung volume and a diaphragm that has pushed down. Lung function tests reveal an elevated residual volume to total lung capacity ratio, a clear sign of hyperinflation. Pathophysiologically, emphysema is marked by destruction of alveolar walls and air trapping, which leads to formation of plebs or bulla. In lung volume reduction surgery, we remove the most diseased and non-functional areas of the lung, typically using a non-anatomical resection that preserves the overall lung shape. This helps restore the elastic recoil and allows the flattened diaphragm to return to a more functional position, improving overall lung function mechanics. You can see the pre- and post-operative MRI of on the right, showing that the diaphragm is coming up after the lung volume reduction surgery. Also, the NET trial demonstrated a clear survival benefit in the group of upper lobe disease due to the high overall mortality in the trial based on wrong or incorrect selection of the LVRS was abandoned in many countries worldwide. Looking at the specific selection criteria in patients were included that should never been accepted to LVRS. In this slide, you can see the inclusion criteria and exclusion criteria of our group in Zurich and the NET trial, and especially the difference in hypercapnia, pulmonary hypertension, and destroyed lung, showing a DLCO less than 20%. When starting an LVRS program, you need to have good results and smooth postoperative course to convince your partners and the referring doctors. Therefore, it is crucial to be very selective and pick patients with marked hyperinflation, upper lobe predominant distribution of emphysema with sufficient lung parenchyma resting. Here you see an upper lobe predominant markedly heterogeneous emphysema in the CT scan and in the perfusion scan. The same patient in the lung densitometry showing a heterogeneous type with the trapped air in the upper part, which is the red part of the lung. Early center studies could show a relevant increase in FEV1 with an at the time acceptable mortality rate of around 5%. Our center could confirm these findings as shown here. We had a surgical mortality at 6 months of 2.4% and an FEV1 gain of 68% in our group. We were able to demonstrate that effect on dyspnea was relevant up to 5 years. Specialist centers were able to show an important gain of quality of life and prolonged survival as well. Out of our cohort, the 713 patients we operated for LVRs, almost half of the patients were female. Median age was 65 years. 97% of all patients were gold 3 and 4, with almost 40% needing oxygen supply at time of surgery. In 2/3 distribution of emphysema was heterogeneous. More than 90% of all interventions were performed minimally invasive, more than half by bilateral approach. Main target zone are upper lobes. Intraoperative complications are very rare and mainly due to severe adhesions. Although our primary approach is bilateral, over the last decade, an increasing number of interventions were performed unilateral. Some of the reasons of this changement are shown here. One of the main reasons may also be that we are facing more and more people in our area having less heterogeneous emphysema, and there we are very careful doing both sides at the same time. So median hospitalization time was 10 days, 30 and 90-day mortality was 0.98% and 2.1% respectively in all these 713 patients. As expected, the most common postoperative complication was prolonged air leak, followed by hemothorax and emphysema, which is quite rare. All patients had postoperative rehabilitation. 2/3 of all patients were discharged to inpatient and 1/3 to outpatient rehabilitation. Apart from the group of emphysema patients with a high probability of improved outcomes, there are two other additional categories. The individuals present with very low FEV1 and severely reduced diffusion capacity, indicating extensive destruction of lung parenchyma. They present the group of highest risk for adverse outcome. In between these two are the patients with uncertain indications. This intermediate group does not clearly fall into either the high benefit or the high risk categories. To show you our special indications in our clinic, this slide here. Over the past 3 decades, our growing experience, advancement in technology, and improved perioperative care have allowed us to gradually expand the initially strict criteria for lung volume reduction surgery. While LVR remains a rare indication in this broader group of end-stage emphysema patients, carefully selected individuals can experience promising outcomes. To show this on the group of repeated lung volume reduction surgery in our selected patient group, published in 2015. Each of these identified factors shown on this slide is individually associated with increased perioperative mortality. However, when multiple risk factors are present in combination, the cumulative risk becomes an unacceptable high, overrating potential benefits. Shown here on the graph, which is the one from the NET trial that should have never been operated on because there was a homogeneous type, FEV1, and DLCO was less than 20%. Our results of highly selected patients with very low diffusion capacity are shown here. Even in those patients, we had an FEV1 gain of about 32%. Another group is the pulmonary hypertension, which is considered a contraindication for lung volume reduction surgery, because it has been reported that endobronchial lung volume reduction may have a benefit effect without increasing mortality in patients with emphysema and PH. We evaluated its effect on PH in patients undergoing LVRs. From January 2014 to June 2016, 119 LVRs patients were performed at Zurich University Hospital. The PH was contraindication for patients with homogeneous emphysema, but was acceptable for those with a heterogeneous emphysema. 30 patients underwent echocardiography before and after LVR. The effect of LVRs on pulmonary artery pressure, lung function, and survival was analyzed. The 90-day mortality for all patients was 0, and the postoperative course did not differ between the two groups. These patients had an improvement of forced expiratory volume in the first second in the median 27 to predicted 33% 3 months after the operation. Therefore, we conclude that in mild to moderate PH, this may no longer be considered as an absolute contraindication for LVRs in patients with heterogeneous emphysema. And this, I have to point out, it's in heterogeneous emphysema, not in homogeneous emphysema. Preoperative versus postoperative PUB in the PH group in patients with median systolic pulmonary artery pressure decreased from 41 to 37 millimeter mercury. Since the early reports on lung volume reduction surgery and the result of the NET trial, numerous studies have confirmed its benefit, including improvement in lung function, quality of life, and even survival. Despite this strong evidence, LVRs remains significantly underutilized in clinical practice. More recently, research has broadened the indication. In carefully selected patients, including those with homogeneous emphysema, low diffusion capacity, or mild pulmonary hypertension, LVRs can be performed safely with favorable outcomes as well. LVRs is now also recognized as a bridging option to lung transplantation, and more recently it's being explored in patients with significant hyperinflation, impaired quality of life, who do not meet classical criteria for emphysema earlier on. Finally, the implementation of various protocols enhanced recovery after surgery and is helping to further improve outcomes in this vulnerable patient group. So there is much going on in this field as well. To finish, I would like to draw your attention to our SINCERE trial to compare surgical versus bronchoscopic lung volume reduction in severe emphysema. It's an international randomized multi-center study directly comparing LVRs and BLVR using endobronchial valves. The goal is to compare efficacy and safety of surgical versus bronchoscopic approaches, focusing on lung function symptoms, quality of life, and severe events. To summarize, many years after that trial, we can conclude that one more time that active treatment for emphysema patients improves dyspnea and quality of life, hopefully with a broader translation into clinical practice. The choice of the procedure depends on many aspects, including laterality, emphysema type, and collateral ventilation. More trials need to further elucidate the difference between surgical and endoscopic interventions. The take-home message for today: condition for successful results, patients access to a lung volume reduction center and a network with your gatekeepers and referring institutions. Very important, multidisciplinary team approach for patient selection. I would like to thank Professor Walter Weder, who was initiating the whole program in Zurich in the early 90s, and especially also to all participants of the emphysema board. And thanks for your attention.
Thank you, Dr. Schneider, for this very impressive presentation, and thank you for sharing your experience. Now we proceed to the next presentation of Dr. Steinack.
You are on mute, Dr. Steinack.
So now you can hear me, right? Great.
Yes, I can hear you.
Okay. Perfect. Can you see my slides?
Yes.
Okay, great. So, hello, good evening, and hello everyone. My name is Carolin Steinack. It's a pleasure to share from an interventional pulmonologist's side endoscopic lung volume reduction. And at first, I would like to thank the organizers from Lexington and Pulmonx for this kind invitation and for the possibility to talk about endoscopic lung volume reduction today. You have already seen this slide with our usually practice, how we do it after exhausting the normal preconditions and the usual lung function parameters when we think and when we discuss interdisciplinary about lung volume reduction. This is a typical X-ray. You have already seen this in Dr. Schneider's slides with a flattened diaphragm indicating high hyperinflated patient. And usually we discuss these patients, all these patients, in our interdisciplinary lung volume reduction board. And here are a wide possibility which technique should be used for lung volume reduction. Of course, we have the surgical part, and when we talk about endoscopic lung volume reduction, we have the possibility to implant valves, to use coils or steam, both are available, or to close fissures before implanting valves. I would like to show you some details in the next slides about that. So it's not so easy, it's a case-by-case decision, and also there are not so many data about randomized trials comparing surgical with endoscopic lung volume reduction. And this was an overview, systematic review and meta-analysis, which just provided details about endoscopic and thoracic lung volume reduction techniques. And it reveals that all techniques have benefits regarding residual volume, lung function, 6-minute walk tests, and also life quality. And the expression of this study in the end was that whenever or whatever you can choose, just choose the best one to have the best benefit for your patient. And what they could also provide is that the less the residual volume will be after your procedure, the better the life quality will increase, the higher the life quality will be at the end. So whatever is possible, whatever is better, just use it. But you can see here in the graph on the right-hand side that almost all techniques can provide some improvement regarding residual volume, which goes in line with better life quality compared to standard of care. So this was the first trial which randomly assigned patient to endoscopic and thoracic lung volume reduction. It was published 2022 at the ERS, and it compared unilateral thoracic lung surgery with bronchoscopic lung volume reduction using valves. They included in total 88 patients, and they used the composite score of the Bode index and residual volumes. And they, in the end, after 1 year, excuse me, they could include that lung volumes did benefit in both groups, and that the survival did not differ between both groups. And this was a non-inferior study, so in the end they could say that both procedures could be considered and are suitable for patients requiring a lung volume reduction. But of course, we need to emphasize here that they compared bronchoscopic lung volume reduction with unilateral lung volume reduction. And we know that in many centers, also in Switzerland, here at University Hospital of Zurich, we use in some cases, you heard it already from Didier Schneiter, we use in some cases bilateral lung volume reduction. And that's why we are right now running the SINCERE study where we compare both techniques, so unilateral and bilateral lung volume reduction, thoracic lung volume reduction, with bronchoscopic valve placement. I will a little bit focus more on valves because valves is the technique that we use most often for our patients here when we talk about endoscopic lung volume reduction. So the next slide will focus a little bit more on valves. And you can see here, since many years, there are different randomized trials, and without going in too much details, I just want to provide you some aspects about these results. So you can see, depending on the trial, these trials were running between 2010 and 2018, that patients improved in terms of lung volume, in terms of exercise tests, and of course also in terms of life quality. So one issue or one prerequisite for patients and valves is the fissure completeness. So without fissure completeness, we cannot place valves because we need to treat one lobe. We cannot treat only a part of the lobe. This is one advantage for thoracic or surgical lung volume reduction. So we need to treat the whole lobe, and for this we need the condition that the whole fissure is complete. Without a complete fissure, valves would not work. And what we use is, as a first step, analysis of the CT scan. We use here the stratics, and you can see here an example. On the right-hand side, on the first row, you see what would your CT scan provide regarding fissure completeness. And here we would have on the left side almost complete fissure. And we know from the studies that a fissure on the left side, which is according to your stratics, according to your CT analysis, lower than 80%, would yield in a negative predictive value of 100%. So it does not make sense to measure it further. The same on the right side when you would have a fissure completeness of lower than 90%. So at first we do the stratics analysis, as also shown here. And afterwards, if we have something that could be a promising result, we usually measure it endoscopically, meaning that we place a balloon during via bronchoscope in the target lobe, close the whole lobe, and then at the tip of the catheter we can measure the flow. And in the best case scenario, we would have a flow that is completely decreasing, as shown in the figure C. So we would say this patient is collateral ventilation CV negative. In a case where fissures are still open, it would be graph D. You can see here with the orange curves, so the flow is still ongoing, so fissure is not negative. So usually this patient would not be eligible for valve placement. I say usually because today we have some more possibilities. Another central question is, okay, now you can treat patients with valves, but what about the whole survival? And this was a very interesting study provided by Professor Slebos in 2022, when he compared his whole cohort with patients who were treated with valves comparing to standard of care, so patients who never had lung volume reduction. And he could show that especially in the first 10 years, that patients with bronchoscopic lung volume reduction and valves, they benefit from this technique compared to the standard of care, with a median survival of 7.4 years. But you can see here around 10 or 11 years later that both lines are crossing it a little bit. And this is, I think, the normal aspect when patients are aging, because our lungs are also aging, and then these patients lose the benefit. But in the first 8 and 9 years, they definitively provide a better median survival. This was a study about valves and how they perform in a 5-year follow-up. The study was provided at the ERS last year from the Liberate study, and they could show that there was still a benefit after the first year, lasting until 5 years regarding lung function. And they could also show that the adverse events regarding, for example, exacerbation and others, that they were lower in the year 2 to 5 compared to the first year. So in the end, they could conclude that also after 5 years, valves still have benefits for COPD patients. So what about the patients without closed fissures? And this is also a cohort which we could maybe treat in the future, because right now we can only treat them in trials. And the first trial is the CONVERT trial. And here is one case report provided. Patients with incomplete fissures, according to the Stratix, between 80 and 95% fissure completeness, they can, if they have gaps in their fissures, you can close them with Ariceal. Ariceal is this polyvinyl alcohol glutaraldehyde. It's like a glue that induces via inflammation closure of the whole fissure. So in the end, the aim would be close the gap and then place the valve. And recent data were provided last year at the ERS by a German colleague, Kite Darwish, and he could show that in these patients who were treated within the CONVERT trial, that these patients with the first endpoint fissure closure, and the second endpoint is lobar volume reduction with a minimal point aim of 350 milliliters, that around 78% from a total included 101 patients converted. And those who converted, 89% achieved the targeted residual volume reduction of greater than 350 milliliters. So it seems to be a very promising approach for patients with open or not completely closed fissures. Right now, still not available, but hopefully in the future available also outside of different trials. So valves are still a foreign body, and foreign body can induce some adverse events as provided here. And the most often adverse event is pneumothorax. We see pneumothorax in our cohort as shown here. Usually I tell patients that we have pneumothorax between 15 and 25% of the patients after valve placements, and usually within the first 24 or 48 hours. And this is really the case in our cohort usually. And following by COPD exacerbation, usually we try to prevent exacerbation by providing already steroids during the valve placement and for a total of 5 days, but we cannot prevent it in all times. Pneumonia or post-valvular pneumonia are a little bit rarer, sometimes hemoptysis. I never have seen valve migration or expectoration. Migration meaning that would lead to expectoration, but according to the studies, it's also possible. And as you can see, foreign bodies can also induce granulation tissue formation, as shown here down on the right-hand side. So Didier, I would just start with my first case, and this is a little bit a sophisticated case because he has a lot of comorbidities. He already underwent heart transplant, and he already had an open wedge resection due to suspicious nodal on the left side, but it turned out benign some years ago. And as you can see here, that the emphysema might be on the first view a little bit homogeneous distributed, maybe a little bit more in the upper lobes. And what we do next is, of course, our lung perfusion scintigraphy. And you can see here that there might be a little bit more upper lobe predominance. And when we look a little bit more in detail what the perfusion scan tells us, we can rather see that upper lobes are a little bit less perfused than lower lobes. And here we have approximately the same on the right and the left side. So Didi, what do you think? What would you do right now in this patient? So, maybe I need to tell you this one before you decide. So please keep in mind comorbidities, heart transplant. He has some, of course, ongoing immunosuppressant, underwent already surgery on the left side. It was an open surgery. It was not in our hospital, but due to this nodal. And now we see an upper lobe predominant lung emphysema with a not complete fissure on the right side. The left side seems to be promising, but right side not, where he never had any surgery. What do you think? What would be our suggestion in our lung emphysema board?
Yeah, when we see these patients together, we look at the different things. And when we look back at the CT scan, we see also that there is some small airway thickening in the lower lobe. So having maybe showing that there might be a little bit more of secretion. When you go down, there is a little bit thickening of the airway, the small airways when you go out here. And they're almost as large as the vessel, so maybe a little bit of bronchiectasis, not too much, but a little bit. So, and he has had, as you said, surgery before, twice. So one resection on the left side and one heart transplantation, which is usually, comes usually with rather severe adhesions, which makes the whole course quite difficult. So if I would see the patient and see also the perfusion scan in this for surgery, I would probably go for the right upper lobe because left is already been attacked once and had been a transplantation. So more severe adhesions probably on the left side, and on top the right side looks a little bit more destroyed, the upper lobe, than on the left. But in this case, I would for sure only do one side. That's for sure. And I haven't seen the lung function test yet. Mm-hmm. So we have to go back to the lung function test and see what this looks like. But it's not an ideal candidate probably for a surgical treatment. That's for sure.
Yeah, and of course the same also for, as the lung is hyperinflated, it fits our criteria. Diffusion capacity was around 34%, FEV1 the same, but the 6-minute walk test was restricted, of course. And I must tell you the same from the side of a pulmonologist, because you see a little bit these thickened bronchial walls, maybe could be bronchitis, then we have this immunosuppression, so maybe not the ideal candidate to place foreign bodies like valves. But in the end, I must tell you, he had this severe hyperinflation and he really suffered from dyspnea. So we wanted to offer him something. And in the end, I must tell you, we did a Chartis measurement, and the Chartis measurement was negative, so no collateral ventilation on the right side. And in the end, I must tell you, now we could give him both opportunities, but of course, we were a little bit, not so happy to offer him something because he's not the ideal candidate and maybe could provide some complication afterwards. In the end, it was the decision of the patient. So the patient decided, because he said, oh, I underwent already surgery for my heart already on the left side, so he does not want to have surgery as a first option. And we said, okay, Chartis measurement was negative, no collateral ventilation. So in the end, we said, because we did not see so many secretion during bronchoscopy, we provided that we could provide or offer some valves. And we did it. I just want to show you a short overview how it could look when we place some valves. So the day before, you see on the left-hand side, normal chest X-ray, flattened diaphragm. And on day 0, right hours after the placement of the valves, you can see that on the right side upper lobe, there's already something that is a little bit more consolidation. And this is usually the first part when atelectasis start. And right after the first day, you can see that the diaphragm is a little bit going upwards already, and that atelectasis is already starting. It was not full developed, but it's already starting. So this is a nice overview how it could look after valve placement. And I would finish, I think, with this case, because we already talked about secretion, and then I think we can open for a discussion and questions. And when we talk about valves, of course, a mucus secretion is a problem, because mucus secretion and valve does not fit, because it could induce some post-valvular pneumonia, and this is usually not the ideal patient. But when we see that, we usually collect the mucus, and when we could collect some bacteria, then we treat them, and this is what we did here. So this patient was collateral negative, and when we treated him 14 days with antibiotics, we just waited 4 weeks more, and the lungs were already clean, so we decided to place valves as shown here. So I just wanted to provide this picture that you can see how valves would look when we place it in the left upper lobe. And I think I would just close here due to the sake of time and open for discussion and questions.
Dr. Steinack, thank you for this excellent presentation. May I ask the participants to ask their questions to the experts? You can write in the chat box, and I can tell the experts your questions. But let me start with the first question. If we implant valves in the upper lobes, we go for a complete atelectasis. On the other side, if we go for surgery, we do non-anatomic resections. My question would be to Dr. Schneiter, shouldn't we go for a lobectomy? What is your experience?
Yeah, this is always, this has been discussed a couple of times. I think when you see what happens as you were absolutely right, when you see what happens when you put valves, so you exclude one whole lobe. So the thing is, if it doesn't work, you take out the valves and it re-expands, and so you are back to square one, right? If you do a lobectomy and it doesn't work, then you're out of game, right? So I would not suggest to do a lobectomy. I know a couple of friends who were also having a clinical immersion at our site. They sometimes did a lobectomy if there was really a heterogeneous distribution, which is quite rare. So we never did that, and we never really did research on it. I know that it has been done, but I have no idea whether how the results are. We would not suggest to do a lobectomy for LVRS.
There is a question from Dr. Pollitt. What kind of magazine do you use for the lung resection? This is a question for Dr. Schneiter, I guess.
Yes. So we usually use staplers with a reinforced stapler line. We started using this kind of staplers maybe 3-4 years ago on a regular basis. Before, we only used it in very severe emphysema patients, and we usually had the normal stapler without reinforcement for all the other patients. But we see a little bit less of air leaks when you have the reinforced staplers. Also, I have to admit that when you go in again because you have an air leak, it's almost never at the stapler site. It's almost always at another site. So that really would mean that it doesn't really matter whether there is an air leak, whether you have a reinforced or not reinforced. But our feeling is that the small air leaks at the stapler line, which are usually only at the beginning, are a little bit less, and so the drainage stays in a little bit less long than without the reinforced staplers.
Another question from my side. We know if we have a patient with FEV1 and DLCO less than 20%, this patient is not a good candidate. But what if FEV1 or DLCO is less than 20%? Only one factor. What do you suggest in these cases?
So there it depends very much about the lung function and the heterogeneity of the emphysema type. So I said the no-touch patient is actually the less than 20% diffusion capacity and less than 20% FEV1. Because usually if you have this kind of distribution in lung function, you never have heterogeneous emphysema, because less than 20% of diffusion capacity means that you have a severely destroyed lung all over. So for that reason, it really depends when you have one or the other, how much overinflation you have. If the patient is very highly overinflated and you see a target zone, then you still have the possibility to do an intervention. But you have to have a target zone, and you have to have a severe hyperinflation. Otherwise, I would not touch. And you would only go one side always when you do LVRS in this kind of patient.
There's a question formulated by Dr. Köschek. Is there a difference doing VATS or RATS compared to air leak problems? And hospital duration is asked.
So it's a little bit a tricky question because we only did 2 robotic cases, so I cannot really compare. But I know that, I mean, we all know that robotic is very nice if you have adhesions. I think there is no better tool than a robot to get down the adhesions with treating the lung very carefully. So I guess there is a lot less leaks due to adhesiolysis when you use the robot compared to the VATS procedure.
I would like to ask the last question to Dr. Schneiter. What is the indication to use VV ECMO for such kind of procedure?
So we never used VV ECMO for an LVRS which was planned, for elective LVRS. We had a patient on VV ECMO who was not able to be weaned because of first a a bullous disease and an air leak and an infection at the same time. So what we did is, in this patient, we closed the air leak doing an LVRS on the bullous disease, and it worked. But I cannot really speak about using the VV ECMO on patients in elective cases. We never use it, even if the patient has a very destroyed lung. Our anesthesiologists, they stay quite calm and they do a very good job. So we can ventilate on one side usually. So the only thing what I would do is, if in a patient who is very marginal, there is probably the reason why you should only do one side. Don't overdo, because doing more is not always better. It's sometimes bringing some harm, having more air leaks, and this might deteriorate the whole procedure.
Great. I learned a lot once again, and I thank both speakers for these excellent presentations. And Zurich is known for their expertise for lung volume reduction surgery, irrespective if it's endoscopic or surgical. And thank you for accepting the invitation of Lexington. And maybe, Thomas, you would like to give us the last words?
Maybe I could, just one thing that I would like to add. So I spoke about the clinical immersion, what we have. So we do have a clinical immersion course for LVRS in Zurich, in Leuven, in Copenhagen. So if you are interested in, just try to reach out for us, one of us, and we try to fix you a date. So this is one thing that we offer. We are all together, so we are with the pneumologist, with the anesthesiologist, with critical care unit, and it's very important that you have a goal that to start or to ameliorate your program, and you have to come together, at least one surgeon, one pneumologist, one anesthesiologist. Okay, great. Thanks.
Excellent. Thank you.
Yeah, okay. Then I also would say thank you very much to you speakers for preparing this webinar and for your very interesting presentations. We went over by 15 minutes, so that means the topic is hot and interesting. Maybe the time is not enough. We will see how we will share further more information and bringing opportunities, what you just mentioned, Dr. Schneider, just to bring people together in a kind of clinical immersion. Thank you very much to all of you around the world for attending for this meeting. We from Lexington Medical and also Promonics would be happy to welcome you in our next webinar, maybe in the second half of this year. So there is no date so far, but we will see if yes, you will get the information. So thanks to every one of you. Enjoy the day, the evening. Have a good time. Bye-bye.